Good afternoon, everyone. My name is Maura Nicola from Bascom Palmer Eye Institute in Miami. And first and foremost, I would like to thank Dr. Pivkianaki and the organizing team for having me. These are my disclosures, which are not relevant to this topic. So today I would like to discuss the use of multimodal imaging in ocular oncology for the diagnosis and management of intraocular tumors. So of course, as we all know, we have many imaging modalities readily available in clinic. So the real challenge when it comes to intraocular tumors is to understand how to use them to our advantage, how to use them for the appropriate diagnosis for differentiating lesions, as well as monitoring lesions over time. So I would like to start with a case. This is a 68-year-old woman who was referred to us for blurry vision in the past 2 months. Her last dilated exam 2 years prior was normal, but when she came to us upon examination, we found the presence of this pigmented choroidal lesion in her left eye along the supratemporal arcade, as you can see here. And the lesion demonstrates the presence of this overlying orange discoloration, which appears hyperautofluorescent on autofluorescence. And you can see that there's also surrounding hyperautofluorescence, which highlights the presence of associated subretinal fluid. So we decided to obtain a B scan, and the lesion appeared to be dome shape with low internal reflectivity. So all of these characteristics here are pretty typical for choroidal melanoma. So the patient was diagnosed with choroidal melanoma and treated with plaque brachytherapy and responded well to treatment. So these are some of the basic imaging modalities that we use for intraocular tumors, fundus photography being the first and most readily available in many situations. It is helpful for objective documentation of the lesion, as well as documenting the evolution and the potential growth of the lesion over time, as well as the response to treatment in case of malignant lesions that get treated potentially with radiotherapy. With the introduction of newer imaging modalities with wide field and ultra wide field, it is now easy to image even more peripheral lesions by only taking just one photos in many cases. So even peripheral tumors can now be easily imaged on these machines. When it comes to interpreting fundus photography, it is important to know if we're looking at real fundus photo images as opposed to multicolor images. So you can see a clear example on the left. You have a real fundus camera, which means that the light source that is used is traditional light to illuminate the fundus, as opposed to multicolor imaging that uses a laser source. And so as you can see here, the color of the lesion can appear completely different. An amelanotic lesion that appears amelanotic on clinical examination and on true fundus photo, like you can see on the left-hand side, on multicolor imaging appears completely green. Here's another example of a small pigmented choroidal nevus in the macula. And again, on the left-hand side, you have the true fundus photo and what it corresponds to clinical examination, so the presence of a pigmented lesion. But on the right side, you can see that on multicolor imaging, this appears as a red lesion. So if we only had the multicolor image, it would be very hard to appropriately interpret this lesion as a melanocytic lesion. So this is why it's particularly important to really know what kind of imaging modality we are interpreting, especially in the context of intraocular tumors where the color of the lesion is an important diagnostic clue. The other imaging modality that we use very often is ultrasonography. This is particularly helpful in determining the characteristics of a lesion, the shape of a lesion, the internal reflectivity, and it's particularly important when it comes to measuring the dimensions of a certain tumor, especially for malignant tumors, where we often use ultrasonography to determine the dimensions of the lesions and therefore appropriate treatment. It can also be helpful in documenting specific morphology, specific shape of a lesion. These are typical mushroom-shaped choroidal melanomas. This shape is almost pathognomonic for melanoma with associated exudative retinal detachments. And it is also very important, again, in case of malignant lesions, in case of melanoma, to potentially document the presence of extraocular extension, because this is going to be very important when it comes to treatment planning. This is another case of a 61-year-old man who was referred for a suspicious choroidal lesion in the right eye. And you can see on the fundus photo here, this can probably almost appear similar to the first case I showed with this small, maybe partially pigmented lesion with overlying orange pigment. Again, this appears hyperautofluorescent, and again, there's surrounding hyperautofluorescence that indicates the presence of associated subretinal fluid. What is very different from the first case, though, is the B scan. Again, we obtained a B scan, and you can see here that the reflectivity of the lesion is much higher than what I showed in the first example. OCT confirmed the presence of subretinal fluid involving the fovea and the presence of this dome-shaped lesion with overlying clumps of so-called orange pigment. So differential diagnosis here includes potentially choroidal melanoma, nevus, hemangioma, or metastasis. But as I mentioned, really the first clue here is the B scan, is the high reflectivity on B scan. And if we want to confirm what this lesion is, we should obtain a fluorescein angiography and an indocyanine green angiography. So you can see here that on ICG, this lesion appears hyperfluorescent in the early phases with a late washout. This is very typical of choroidal hemangioma. So this lesion was in fact a choroidal hemangioma. And the fact that in this photo that I showed in the beginning, it appeared partially pigmented, again, it's important to note that in this case, we're looking at an Optos photo, and this is a pseudo-color camera. So sometimes the coloration of the lesions can appear a little bit different on Optos photos as opposed to clinically. Clinically, this lesion appeared not so pigmented, much more orange in color. So the patient was in fact diagnosed with a choroidal hemangioma, and you can see how nicely it responded to photodynamic therapy. And 2 months after, the lesion is shrinking and the vision is improving. So FA and ICG are not necessary in all cases of intraocular tumors if the diagnosis is clear, but they can certainly be helpful in certain cases for differential diagnosis, like for instance, in choroidal hemangioma, as I mentioned, but also in conditions that are non-neoplastic but can mimic melanomas, such as this one that was referred for a possible melanoma. But you can see here that when you get FA and ICG, the lesion remains hypofluorescent throughout all of the phases of the exam, which indicates that there's lack of intrinsic vascularization, and this is in fact just blood. So this is related to the presence of a so-called extramacular CMVM, or peripheral exudative hemorrhagic chorioretinopathy. As I mentioned before, autofluorescence is particularly helpful in highlighting the presence of lipofuscin pigment. So this is often called orange pigment, but it's important to note that lipofuscin pigment appears orange when overlying pigmented lesions. However, it can appear brown when overlying amelanotic lesions. Whatever the case, it always appears hyperautofluorescent on autofluorescence. So this is a particularly helpful modality in confirming that we are in fact looking at lipofuscin pigment. It's important to note that while it's often associated with choroidal melanoma, it is not pathognomonic for choroidal melanoma, as it can be found in other malignant and non-malignant conditions. As I mentioned before, hyperautofluorescence is also indicative of the presence of fluid, of subretinal fluid, so often it can be useful in detecting subtle subretinal fluid. And it can also indicate the presence of choroidal compression and thinning due to scleral unmasking. So here are some examples of how nicely autofluorescence highlight the presence of lipofuscin pigment as well as shallow subretinal fluid. But as I mentioned, this is not pathognomonic for choroidal melanoma. You can see that it can be found in other conditions as well, both malignant and non-malignant, such as this case of posterior scleritis here. So this is another case of a 73-year-old man who underwent trabeculectomy. After trabeculectomy, the pressure went down to 8. And when they did a dilated exam post-surgery, they noticed this pigmented lesion, which was concerning for melanoma that was not previously noted. Of note, this patient was on warfarin, was on a blot thinner. So you can see here that autofluorescence does not show the same pattern that we've seen on other lesions. There's really no overlying lipofuscin pigment. There are some radial folds here that can help a little bit indicate what this might be. And you can see this folds on fundus photo as well. Here, when we get the B scan, this is a little bit non-specific. The lesion appears somewhat hollow, somewhat with low reflectivity. And when we get fluorescein angiography and ICG, it almost seems like there's no lesion there. So this doesn't really help us. It doesn't really highlight much. It doesn't really indicate much. So what's the clue here really is the OCT. So when we obtain the OCT across this lesion, we can see that the lesion is actually located in the suprachoroidal space, which normally is a virtual space. But because of the presence of blood here, it becomes a space that we can actually see on OCT. So it's clearly delineated on EDI OCT due to the presence of blood. So this patient had a suprachoroidal hemorrhage, likely related to the low IOP post-trabeculectomy and the use of blot thinners. It is important to use enhanced depth imaging or EDI technology when looking at the cord. So when dealing with intraocular tumors, I always recommend obtaining EDI OCT. So OCT is particularly helpful in determining the level of the lesion, where it is located, if it's in the retina, choroid, or even in the sclera, again, with the use of EDI and swept source technology. And it can also help in the in differential diagnosis because different lesions are going to have a different shape, different morphology. And of course, it's helpful in detecting associated features such as subretinal fluid or CME in certain conditions. This is OCT can be also helpful in differentiating between between a choroidal nevus and a small melanoma. It is not the only modality and the only criteria that we use to differentiate between these two entities, but is one of the things that can be helpful. For instance, you see up top that we have subretinal fluid, shallow subretinal fluid. However, there's minimal elevation and there is photoreceptor loss, which is indicative of the presence of chronic fluid that has determined the loss of photoreceptor. This is more often associated with choroidal nevus. On the bottom, you can see a smooth surface of the lesion, but the photoreceptors here are definitely more shaggy. So this is indicative of a more recent phenomenon, potentially associated with the presence of a small choroidal melanoma. Again, this alone cannot make the diagnosis. Of course, we use other clinical features and other imaging features to differentiate between the two, but OCT can be helpful in this setting as well. So this is another case of an 83-year-old woman who was sent with decreased vision in the left eye for the past 5 years, and she was referred for the presence of this somewhat atypical macular mass in her left eye. You can see here that the reflectivity on B scan is pretty high. When you get an FA and ICG, this doesn't, the findings are somewhat non-specific. It doesn't really help us much. But when you get an OCT, again, here you can really characterize the lesion. So this is, it helps us not only localize the lesion, so this is actually a PED, but also its characteristics is a fibrovascular PED in the context of AMD. So in this case, OCT was helpful in differentiating between a non-neoplastic and what was suspected to be a neoplastic condition. Here I have another case of a 70-year-old white man who was diagnosed with the presence of this amelanotic lesions in both eyes, and this was an incidental finding during a yearly dilated exam. So of course, when we see bilateral multifocal amelanotic lesions, the concern is always that there could be metastatic disease, and this patient actually even had a remote history of prostate cancer. So of course, there was a concern for potentially a metastatic disease to the eye. When you get the autofluorescence, you can see that there's hyperautofluorescence corresponding to these lesions. But really, what makes the diagnosis here is the OCT, because based on the OCT, again, we can localize where the lesion is, and we can tell this is not a choroidal lesion, but it's in fact a scleral lesion, which is partially compressing the choroid. And because we know that the sclera is intrinsically hyperautofluorescent, when we have any sort of overlying choroidal or choriocapillaris compression, we're going to have scleral unmasking, and therefore this is going to look hyperautofluorescent. So this is typical morphology for sclerochoroidal calcification. And when we get a B scan, we can confirm the presence of calcium that you can see in this image with high reflectivity and posterior shadowing. This was another case of a 49-year-old woman who was also referred for an amelanotic mass in the right eye, and she also had a remote history of breast cancer. So even in this case, there was some concern that this could potentially represent a metastatic disease. When we got here you can see that the B scan was taken with two different probes. On the left, you have a 15 megahertz probe, and on the right, a 20 megahertz probe. The 20 megahertz actually helps characterize this lesion a little bit better, and you can see that it seems to be within the sclera itself, even though it's not super easy to tell based on ultrasound alone. But again, when you get the OCT, the EDI OCT, you can really localize this lesion in the sclera, not in the choroid, with partial compression of the choriocapillaris, again explaining the scleral unmasking and therefore the hyperautofluorescence on autofluorescence. Here, this is typical for the presence of a focal scleral nodule. So this patient was actually diagnosed with focal scleral nodule, which was previously known as a solitary idiopathic choroiditis. So again, with imaging alone, we are able to differentiate between what was thought to be a malignant neoplastic lesion versus a non-malignant lesion. This was previously thought to be choroidal, but again, the use of EDI-OCT shed light to its real nature and to its real location. So this is, in fact, a lesion that is located in the sclera. So as I mentioned before, EDI-OCT can be helpful in the differential diagnosis of many neoplastic conditions, as they will present different shapes. So starting with choroidal metastasis, they usually present a pretty lumpy, bumpy surface with associated subretinal fluid. And oftentimes, the amount of subretinal fluid that's associated with choroidal metastasis is disproportionate compared to the size of the lesion itself. So that's another diagnostic clue there. Choroidal hemangioma tends to present with an expansion of the choroid because, of course, it's a choroidal vascular tumor. So we will not see the choroidal or choriocapillaris compression that we see more often in choroidal melanoma, but we will see a choroidal expansion, usually a smooth surface, and an associated subretinal and intraretinal fluid often. Choroidal lymphoma, somewhat similarly to choroidal metastasis, can show a lumpy, bumpy, but more often what is described as a seasick, rippled appearance. And again, expansion of the choroid here, with loss of the normal vasculature, loss of the normal choroidal architecture due to the presence of neoplastic cell in the choroidal space. And finally, choroidal osteoma, of course, we can always use ultrasound to confirm the presence of calcium, but even OCT alone can give us a pretty big indication that this is a choroidal osteoma, because you can see the typical lamellae on OCT pretty clearly in many cases. Finally, there's been the introduction most recently of OCT angiography. So this is a non-invasive modality to study the retinal and choroidal vasculature, pretty much just using a red blood cell motion as opposed to injecting a dye. In the space of ocular oncology, there's active research as to how to use this modality, but two important ways that this can be used is to assess the level of ischemia post-brachytherapy in those patients that are treated with brachytherapy or with radiation in general, and to detect the presence of choroidal neovascular membrane, which can be associated with choroidal nevus. And I have a couple of examples here. Here you can see a patient that was treated for a large choroidal melanoma in the left eye. So here on the left-hand side, you can see his right eye with normal vasculature, and you can see here in the middle how significant the capillary dropout is after brachytherapy. This is particularly important because it can give us an indication as to whether or not it is appropriate to continue treating this patient with intravitreal injections of anti-VEGF, which we often do for a radiation-related complication such as radiation maculopathy. So you can see that there's still intraretinal fluid here. However, it might not be indicated to continue treatment for this patient because even if we get rid of this intraretinal fluid, the macula is very ischemic, therefore his visual potential might be very limited. Here, I have an example of what I was mentioning before. So using OCTA to detect the presence of an associated CMVM, you can see clearly a neovascular network overlying this pigmented lesion that demonstrated some overlying blood and exudation. This is also important because sometimes it is difficult to differentiate between choroidal nevus and small choroidal melanoma, but the presence of a CNVM is an indication of chronicity. So it's more often associated with choroidal nevi as opposed to choroidal melanoma. So again, this can be a helpful diagnostic clue. So in conclusion, when it comes to intraocular tumors and imaging modalities, there's no one imaging modality that is superior to others or that can be used invariably in all lesions. And not all imaging modalities are needed for every case. So it is important to know what each imaging modalities can tell us about each tumor to use them appropriately. Combination of different modalities can lead to timely diagnosis, and it is very important to appropriately use multimodal imaging to correctly identify posterior tumors, as well as to monitor for a response to treatment and potentially complications over time. Thank you so much for your attention.